list of people coming. We are monitoring who is coming in, and we hope Marilyn is joining us at some point. But I start with one question to Jochen. I think there has been a lot of discussion on technology, especially virtual reality, augmented reality, also the tracking technologies for health. But so far, it is really something for the geek. And I think yourself, as somebody who's running a lot, I think that the tracking for people who run, again, this is sort of something where we see the geeks. And if we go into mainstream, be it care, be it hospitals, be it chronically ill patients, we have seen the one or other app, but we really haven't seen a mainstream uptake of VR, AR, and tracking technologies. What do you think is missing? What are we missing with our research? And you being at an institute that also looks at applied research, what is it missing that it's not going out to the public?
Well, I think the tracking so far has mostly been kind of intentional. People have used tracking because they were running and they wanted to improve their running, or because they were diabetes patients and they needed to observe their diabetes. I think so there was some intention to use tracking for a given purpose. It was purposeful. I think what we now can observe is that tracking becomes a byproduct of the digital life. And when you think about smartwatches, they may be the very best example. You often will have a smartwatch just because it's a cool device, it works well with a smartphone. And as a byproduct, you get a lot of self-tracking. And that may be one of those points that considerably contribute to self-tracking becoming really seeing large take-up. And I think we can also observe, so it's mostly about reducing barriers, making the potentials of self-tracking more visible, lowering the entrance barriers. And when you just have a smartwatch and you can see, hey, there is some tracking, you can see your activity, you can see your sleep, you may get interested, and this may really be the starting point.
I'm wondering, like quantified self, especially when you are running, like the naive approach may be to kind of compete with your own path to see, I increase like the distance I run, but there must be more. Like, are you running against others? Are you using are you try to run in different cities? What kind of features or data correlation you are using?
Also, again, I think it's, I would like to make a difference between short-term tracking and long-term tracking. I mean, it's a continuum, clearly, but when you think about short-term tracking, you may think about an intervention. And you may say, hey, I want to know how good is my running at the moment, how much is my physical activity, am I active enough in daily life? And you may say, I want to increase my physical activity to reduce my weight. Classical health behavior intervention, that is one use case. So there you start with an intention and with a clear purpose, and use the tracking for the given purpose. When you think about unintentional tracking as a byproduct, when you think about tracking for very long term, tracking just because you can track, then you get very different use cases. You do call when you have a smartwatch, even when you have a smartphone with like Apple Health activated or something. You do collect data about yourself and without even taking care about it. So after like 2 or 3 years, you may have an amount of data that you suddenly find interesting. And use cases there would be very different in my eyes from short-term tracking. So you may think about, are there changes, slow and unnoticed changes in my behavior or in my vital parameters? Did I develop over time? Were there some adverse events in the past, or I am aware that I have faced a change in my life? What can I learn from my past about my future behavior to really tackle this change? I'm aware that like given Corona, working in home office, I lack my 2 times 20 minutes of cycling to work and back every day. So looking into the past, how much physical activity did I have in the past? So facing the future, what should I do in the future to kind of sustain my behavior and kind of sustain my health?
Okay, so I think that that's a good transfer to one other. So I think Marilyn has joined us, and I think we've mixed up sort of time zones. Sorry about this, but I think it's nice that you jumped in. But before we put you on the spot, I have already talked to Yasmin on the chat, because I think giving you sort of another 2 minutes to settle in, and then Yasmin, I think we can unmute you. Let's see if this works. And I have one question. I think Jochen just talked about sort of one end of the spectrum, especially people who are sort of aware of their, it's a lot of self-management at the moment if we talk about tracking. In your research, you look at health at a, basically, I would call it nearly the other end of the spectrum, vulnerable populations. And again, there, I think I've seen some of your work really sort of the very big potential of technology, and here too it's not yet there. So what is the missing piece? How we do transfer the ideas that happen in research, the ethnographic studies, the research probes into something that's really changing people's lives?
Yeah, hi to everyone. Thank you for the opportunity to participate here. I think one of the biggest challenges here is that we actually have to push ourselves as researchers to look into this direction, because I feel like in recent years it became very fancy to say, yeah, let's include vulnerable populations, let's include different cultures, but we as a community are still not there yet. If you look at our samples, if you look at most of our studies, and I think that's where it starts, to really go out and to talk to people who identify with different communities, just like the LGBTQI+ community, for instance, or who suffer from specific difficulties, like people with eating disorders, how they use fitness trackers, and then to actually really listen to their stories and what their specific needs are and how we can design for that. Instead of just saying, okay, how can we transfer the insights we already have? I think we should really be self-critical as a community and ask ourselves, are the insights that we have already gathered applicable to vulnerable populations? So, yeah.
So I think one just digging a bit down there, I think one of the things which was really sort of on vogue already 20 years back is the design for all. And I think we have seen that a lot of companies have managed to do that. I think the iPhone was something that was sort of an elderly phone, at least in the price. You had to be quite you had to have money, but you could see a lot of old people using it. And the old people, the phones designed for old people were not really sort of cool with that part of the population. So is sort of something, do you expect the learnings from sort of smaller populations where we would, because I think I'm worried designing specifically for one type of population makes it even more tricky. It makes them even stand out more because they use the specific device. Do you think sort of, how does it go together?
I think one way forward is to really, and I'm sorry for using a buzzword here, to look into the direction of empowering the user, to really think about, okay, how can we offer different kinds of options for the user? If we use the example of fitness trackers, for instance, we have highly motivated, highly self-motivated people who use the fitness tracker to get even fitter, for instance. And then we look into the other direction where we have people, for instance, who struggle with an eating disorder and they move too much already because they should save on calories, so to say, to simplify it a bit. And then what we can do is we can offer different kinds of options to provide feedback and to communicate with the user. And then every user for themselves has to be able to make the decision what kind of feedback they need in a specific moment. So for instance, as a person who is already too self-conscious and too careful about what they eat, how much they move, and things like that, maybe a feedback option should go into the direction of offering self-compassion but that could also work for someone who is fit, mentally stable, physically stable, but still a bit more prone to ruminate or to negative thought cycles. And that's where the different user groups can learn from each other to offer a wider spectrum, a wider design space for different users.
Okay, and I think with this, I hand over to Katrin for the introduction.
Yes, so I'm really happy that we have Marilyn here. Stephen, you probably can put her microphone on, or Marilyn, you can unmute you. So I met Marilyn, I think it was, thank you, 2011 when I did my internship with Stephen, and Marilyn was a postdoc there, and she already worked in the domain of health and well-being. So, and now she is still in Glasgow. She's a reader in Strathclyde and a founder and director of the Digital Health and Wellness Group. She has a lot of research focus, so she works on, for example, mobile life tracker, also smart homes, etc. And so she can really talk about anything probably we discussed in the last weeks, but I just start with something that Jochen mentioned. So he's kind of the most honest self-tracker because he is tracking his own sport exercise over years. And you, Marilyn, you work on evaluating digital health. Can you maybe briefly tell us what technology you use and also what AR technology could enable you as a researcher to evaluate health?
Thank you, and thank you for having me. Sorry for being fashionably late. It was not intentional. It was out-based. So yeah, I did think when I suggested to speak, I thought, gosh, I sound like I do everything but don't do anything specifically. But I kind of do that intentionally because my background is computing science and psychology. And so like really early on, like you said, Katrin, I was kind of like, how can I combine that? So before digital health was a big thing, I kind of started doing digital health. So the answer is really, I've jumped around quite a lot of different tools and technologies, but I do that purposely because I'm really interested in the methods that we use to try and make technology augment what we do, rather than trying to fit the technology to solve specific problems at any one time. So just as one example, I'm not a VR or AR expert, by the way. I'm kind of much more an observer on how that can help in the health and wellness field. But one of the things that I did do around about 2014 was, like most people, jumped on the gamification bandwagon and thought I could gamify some of the health and wellness things that we were trying to do at the time. So we developed a game for mobile phone platform, but we did that game development in conjunction with a large sporting event. So it was the Glasgow Commonwealth Games was in Glasgow that year. And we tried to gamify people walking around the city with their phone anyway. And inside that game, we gave reward points for doing walking trails or visiting certain buildings. But I guess the point was that ultimately we wanted to make people walk more. So the points were awarded based on step count, but we just kind of nudged them gently in the direction of the way we wanted them to go. So we never called it step count because we felt that would put people off, that it would sound like yet another step count app. But by calling it energy points and giving people points for doing stuff in the city, people got obsessed with the game. So they actually did more exercise to unlock more levels. So even if they ran out of lives, they would jump up and down in the spot to get more lives. So, and that application was kind of, mixed reality in the sense that we're trying to exploit putting digital motivation and physical motivation into the same app. And it kind of worked. So that's one example where we got a wellness benefit, but it was sort of indirect.
Okay. Albrecht, do you have one, or shall I continue?
Yeah, if you continue, I sort of sort myself out with the rest of the question.
So I like what you say reminds me on Pokemon Go a bit, like in a sportive way, and we come to a point where we share data. So our sport data, this is a prediction for our health, and I think in Germany we are particularly like scared about data sharing. But this is a global thing, of course, and so I'm wondering, like, there's always this dystopic scenario that health insurance one day will say, you are not our user, you're not our customer because you barely move, and you would be a risk for us, like a a commercial risk. What are your thoughts about that? Is there a trade-off? Like, I don't know, is there probably a technology solution, or what, how do you think we can solve that?
Yeah, I love that. I love this question because I really don't know what the solution is. But I'm fascinated by this because I get, we have like reward cards for shopping. I'm sure you probably know. I get leaflets through that tell me you can get £1 off a packet of crisps or a bottle of vodka or shampoo, and it's all extremely accurately based on all my previous purchases. So on the one hand, I really value that because it's giving me what I want. But on the other hand, I'm really worried because if Sainsbury's or Tesco or Boots the pharmacy know that much about me, it does make me worried that they can then withdraw services or withhold services if I need an operation. They can just say I drank too much vodka or I ate too much butter, or so even I'm scared as a researcher because the potential to abuse data is really prevalent. And I do think there are organizations who have shown previously that they will abuse data. However, I think in HCI and in user experience, we have always said you will only do something if the perceived benefit is greater than the risk, right? So for me, if my shopping experience is improved by them knowing what I buy, in the health and care context, the same is true. If I can get better healthcare in the future based on what Scotland knows about my current lifestyle, and that gives me better care, then I'm willing to contribute that data, right? It's only when it's abused that you start to worry.
So I want to dig down there a little bit, because I think that's one thing we realized with technologies like mobile phones, but also even more with AR and VR technology. So I think there's one simple example which we just stumbled across. Probably Google or Apple knows how well your eyesight is, because they know how big you are. So they probably know a lot about you. And I think we cannot hinder it, because you will basically zoom in, zoom out. You will have the phone on you where you go. And so my question really is it a research issue, or is it not really a policy issue? So I think you hinted it's basically where it's misused. And my take would be, I think we will collect a lot of data, because for some of the things we just need it in order to make, and I think my take would be we have to have laws in power to prohibit people from using that data, rather than sort of restricting ourselves of collecting that data. And I think this is sort of something where we are in a sort of a dilemma, especially now. I think we restrict ourselves also in research with, I'm heading the ethics committee at LMU, at the informatics or computer science. And I think there are a lot of these discussions, what can we collect, what can we not? And I think the big companies, they collect it because they create a better experience, and they will tell us. So what's your take on this? Is anonymization a way, or do we really just rely on laws? And why are laws so slow in that space?
Yeah, I agree with what you're saying there. I think, well, if I was purposely controversial, I would say that why is health and care so different, right? Banks store our data, holiday companies have my data, shops have my data. as soon as we talk about health and care, the level of anxiety and fear seems to be tripled. And I understand why. However, I think I'm agreeing with what you were hinting at. I think all data is just data, right? Before it becomes contextualized to mean something. So if health data is anonymized and or it's aggregated up a level so that you can't tell it's me, and if there are adequate data protection governance and laws to protect it, as there are in financial institutions and other industries, then really I think we should collect and maximize the use of the data as much as we can. And I don't think we can improve our health and care systems for the next 10 years unless we maximize the use of that data. So I would say it's the responsibility of us to try to push the boundaries and collect the data through new AR, new sensors, new wearables, but for us as a community and others a higher level up to provide guidance and safe practices for doing so.
I think it's a really interesting point. Also, if you look to Scandinavia, where a lot of data is open, and if you read sort of medical research, a lot of the research comes out because there is open data or data available, which is on a population scale. And so I think it's an interesting, and I think also it goes together with how we pay for healthcare. And I think the UK is an interesting part where basically if you don't have insurances, if you basically have a general healthcare system, a lot of the worries may not be that real. But I think once you go into a private healthcare system, like in the US, sort of the incentives of mining your data to figure out whether you will be a good customer or a bad customer is huge.
Yeah, there's a lot of money in data, and no matter how open we try to be with data, some businesses make money from being the data owners, so they're not necessarily open to sharing their data. And from researchers' point of view, the more we can curate, diverse, really varied data sets, the more cool research we can do, right? But the data owners are not super happy to do that because they can charge us to access their data.
I was wondering, when we talk about tracking health activity, I think we often talk about we track movement and assume that is walking or cycling. But from companies, we see a lot of effort in behavior change, which means consume more. Like Amazon, if I buy an espresso machine, it shows me even more espresso machines, but also coffee and filters, etc. Maybe I missed that, but shouldn't be more effort in making me living healthier from coming through the browser, coming through, I don't know, proposing me to buy something that is healthy, or do I just not, is it just not my profile and it's already out there?
I know it's kind of a weird one because for a long time now, there's this sort of movement to do nudge theory, to nudge us in the right direction rather than prod us, So if I try to buy full fat Coca-Cola, I really don't want Amazon saying, would you rather have, orange juice, right? Well, maybe that's a bad example, but nudging me in the right direction, incentivizing good behavior is probably a better way to go. And there's proof to say that incentivization is a much better way to go. And I remember somebody once at a talk I gave saying, in Scotland, why don't we, rather than withhold NHS services because you drink or you smoke or you, jump off cliffs at the weekend for a hobby, instead of doing that, why not reward people for healthy behaviors with credit? And that would be virtual credit, not quite Bitcoin, but virtual credit where you can cash that in later life. So you would then spend your virtual behavior credit on accessing cool things later on when you're older.
Mm-hmm.
So I think this is sort of it's sort of triggering something in me. I think this is the question: what is good behavior? What is sort of healthy behavior? Who decides what sort of? And I think especially if we go towards mental health, it's sort of, oh, you haven't met 3 friends this week. I withhold some of the credits. And I think sort of the plus minus calculation, it is not just, I think sort of, you basically say withholding services versus giving something, but I think is this sort of on a overall view not the same if you, but I think the first question, I think that's something I find really sort of, especially in a democratic system, who decides what's healthy, who decides what's good for me? And typically we have sort of in our societies this idea that I decide for me, and I may live with consequences, but there is no bigger power that tells me 3 times a week you should meet friends, not 5 times, because then you may drink too much. And sort of you should go out 1 hour. If you go out less than an hour, you're not healthy. But if you go out 3 hours, you may sort of catch a cold. So who is going to decide this? Do we really want sort of this nanny society?
Yeah, and also health outcomes and wellness outcomes are not always perfectly correlated. So for instance, I met a 91-year-old man and I was interviewing him about technology in his home, and he had, his pockets were full of sachets of salt that you get in the restaurants. So his sister would steal them, well, not steal them, bring them from the restaurant. He kept them in his pocket because his care worker took all the salt out of his house because he needed to manage his, I guess, his sodium levels. So she would remove the salt from his house. His sister would then bring the salt into the house. Then when she visited, she took the salt back out the house. So it's constantly, you know, the care worker was trying to manage a specific health outcome. But that person who was 91 made a conscious choice that he wanted salt in his food. So he should be allowed to eat salt in his food. So there's a very ethical dilemma where we have to decide there might be a health outcome that we can achieve if we don't do X. I might want to do X to make myself happy. So,
and the thing, but now bringing this back to HCI, and I think HCI, if we read papers that are published in CHI and Tokai, etc., we see a lot that it seems HCI people know really what's good for the world. And I get really very often pretty much annoyed about it. And I think sort of as one of the things you said is basically, is quality of life equal to length of life, is sort of all these things, which are, I think, very highly individual choices. Are we missing research in that space? And what would be topics, if you had a free PhD student, what would be topics to counter that issue?
oh gosh, I think that's a good question. I mean, I think you touched on one. I think if I had 3 PhD topics, one of the ones that I would definitely look at based on what you just said is to try and look at the more meaningful capture of like what was traditionally called patient-reported outcome measures. But I would like to look at contextual that we can measure in the home. Either the home measures it through our smart TV or through our microwave or our smart fridge, and also through wearable devices. I'd like to try to see if that can tell us more about how we live and what makes us happy. So I would like to do a happiness PhD, but how the sensor data can tell us how happy we are. I don't think that's an easy HCI problem because I don't know how you measure happiness either, but maybe that's 3 PhDs.
So I think I just give one response there and then hand over to Katrin. We had the discussion of happiness, and I think we cannot maximize happiness because you have to be unhappy in order to be happy. So should the HCI researcher modulate my happiness? So, but I hand over to Katrin for the next question.
Yeah, we have a baseline or a control group. That would be a little bit unethical to make everybody unhappy so that we could make them happy again with our technology.
Sounds a bit like Facebook, but...
No, but I have a similar thought. Like I thought I sometimes have to do something that is not super healthy to then, you know, like be stronger to kind of take care of myself. So I think we kind of agree that it's not a simple like follow the rules, eat healthy, do sports, etc. And I don't know, should we all, you know, should we kind of shift this to the machine learning people and let them, you know, investigate patterns, or what's the way to evaluate this? And I don't know, you are an expert also in evaluating it. So do you have maybe some like examples, like how to measure happiness, how to measure health, how to measure like quality of life? How do you do that?
I don't know if I know how to measure happiness. That's the short answer. But in terms more generally of, you know, AR and VR and health and well-being and how you evaluate that meaningfully, it's not a new thing to say this, but I think we need to get out of the lab quicker. And I love lab studies, and I've run many lab studies, and I'm, you know, true to scientific process. But I think in health and wellness, there are lots of technologies in HCI which are not used yet in the application area because they've not passed an RCT trial, or because people are labeling everything a medical device. So I would like to see evaluations where proper, good, solid HCI technologies or methods are rolled out into health services much quicker. Because we've learned so much in the VR and AR kind of HCI arena, but it gets stuck. It gets really stuck in the research lab. Get why? Because things have to be safe, and they have to be effective. But I think if something's proven to be safe, I'd much rather get it out and do much larger kind of real world trials much sooner.
We had last week, we had Igor Sauer, who's a surgeon from Charité, and we had a little discussion a bit on how to do that. So how to bring things into hospitals. Also, Susanne Boll is in our audience, and she also worked with hospitals and find this extremely hard. So how's your experience? Who do you work with? You know, who are the stakeholders, or who are the people that help you bringing your work to the people?
Yeah, it's difficult. So it should be quite easy in Scotland, right? Because we're fairly small. Our health and social care organisations are pretty much integrated, and our kind of SME community in the area of health and wellness they're fairly small. So there's a couple of things we do that we're doing quite well in Scotland in terms of sort of new technologies and AR and VR technologies in health and wellness space. And some of them are a bit more at the sort of governance level. So number one, the hospitals are really risk averse, right? For a good reason. So if a small company, if Katrin has a really cool device, she's done a really cool EU project to show how brilliant it is, she can't just walk into a hospital and roll it out tomorrow. She'd have to probably go through an RCT and so on and so on. In Scotland, they developed something called an innovation partnership, where we can work with the hospital from the outset rather than do a big HCI study and then go to hospitals. And the Scottish Government have got a platform where we can wrap up a service evaluation with a research evaluation to try and get the technologies into the hospitals much quicker. And it means that smaller companies can get in quicker, because at the moment, probably true where you guys are, but in Scotland, they tend to go for the big companies because they've got really good insurance. So all the smaller, more innovative, cool stuff coming out in VR and AR can't get into the NHS because it's too risky. These innovation partnerships are giving them a step in to get into the procurement system so they can work with hospitals from the outset, which is really, really, really good. And one recent cool example is a small company in Scotland that have developed an ingestible capsule, where it basically takes pictures of the, it's an alternative to a colonoscopy, so it's less invasive. It just takes basically and transmits them back. And they spent years trying to get into the NHS, and until this innovation partnership was formed, they couldn't, and now they're in 4 different health boards, not as a research project, but as an actual routine service. And that was a really good example of how to get the cool tech out much quicker into the hospitals, or into the community in this case.
Cool. Albrecht.
Okay, so I think please write questions into the chat. I think we have already some coming, and I have one, and then we switch over to the chat. So I think you worked on smell and odor. And I think this is one of those technologies I think I've been excited for quite a while. And can you tell a little bit about it, and what sort of the insights, and what are the open, if somebody wants to move into that space, what are the cool things people can do and what are the things that are not so easy to work with? So if you just run us a little bit through the projects you did and give us sort of some hints where we could go in that direction.
Yeah, so olfactory stuff, olfactory devices is one of these kind of immersive technologies which are really powerful, right? Because you know, when you smell something good, it reminds you of your holiday or a place you visited. And if you smell something bad, it can evoke, you know, real kind of reactions. And if I have 3 PhDs, as you asked me before, maybe one of them should be in olfactory sensing, because there's so much unknown, and it's almost like some people think it's gimmicky, like it's not, there's no real killer app. But the best use I've seen of it is in sort of reminiscence therapy for adults with dementia. In this case, it was older adults, but it could be used for any age. And we attached smells to a memory box. And because the smell was one of the senses where they didn't lose the memory attachment, the emotion that was evoked by smelling, you know, a log fire or a certain flower really aided in the well-being measurements of the older adults, more so than the pictures did, more so than video did. So the olfactory stuff was really immersive and really emotive. We also tried to, and this is maybe a negative example where it didn't really work, we tried to attach smells to a reminder system to tell older adults when to take their medication or when to take the bins out, or, you know, when to go to bed, for example. And those associations, because we were trying to create new memories, were not nearly as successful, and people really hated it. But it was a really quick lesson in HCI to figure out what people liked and what they didn't like.
Okay, cool. So,
and I just put also a link to your Scholar profile with some of the papers on sort of in the chat. So I think if you want to read up more on it, please have a go. Now, Katrin, are you taking?
Yeah, we have Hannah Schäfer, and Stephen is putting a mic on. She's already with a video. So please ask your question.
Hi, so I love your work and I love all this HCI tracking stuff for health. I've been working on food recommendations before, and we really saw lots of differences in different age groups of people. So maybe I was wondering if you could just tell us a bit about your experience, like how do you design for children and then the same app for elderly people? That is probably quite challenging. What's your approach there?
Yeah, it is really challenging, but in some ways the answer is sometimes well, it's not that different because different people are different regardless of age. So that's true. But in the other sense, it does depend a lot on the age group as to what motivates people and also what technology they might engage in or not. So a good example would be that we finished a study where a PhD student of mine designed an interactive toy, a sort of tangible game, if you like, for educating really young children, sort of age 3 to 5. And it basically taught them about carbohydrates intake and how it affected their diabetes. And we made an awful lot of assumptions. You know, we said that it would be an app, and straight away they were like, they didn't want an app, they wanted a walk-up kiosk. So kind of old school standards. You know, we used to do it in HCI, but it was a standalone kiosk. We also then tried to integrate it into toys, like cuddly toys, you know, teddy bears. And the children told us, nope, that's too immature. We don't want cuddly toys. So nothing new in terms of HCI research, because we knew we needed to ask them, but we made a lot of assumptions about young children that were completely wrong. And then I guess the same is true at the older spectrum. So we also assumed that our older adults, the ones who were managing type 2 diabetes, would not like to track as much through the app, and they actually ended up tracking more than our younger adults. So our young teens with diabetes didn't want to track anything, right? Because if they track it, then they can see how badly they're managing their diabetes. So it was not in their interest to track it because it would tell them what they already knew. So I don't think that the differences are so much in the technology, but maybe in the methods by which we use the technology to engage people in the behaviours we want might be different for different age groups. But then again, I've spoken to 90-year-olds who asked me to not email them, but to WhatsApp them. So we can't make any assumptions, right?
So I think one question to look a bit more into that is, I think that the question about user-centered design or human-centered design, and I think some of the things, it's really valuable, as you said, you basically make assumptions, but some of the things people don't know what they want. So I think with the children, I think this is a positive example, and that's usually what we teach in class. You go to the user, they tell you something you didn't know, and you figure something new out. But then sort of the other thing, you go to the user and they say, I don't want to have this technology. Once they have it, they use it heavily. I think that's the other extreme also, I think, experienced. So do we have to rethink what human-centered design is? Should we have sort of just really rethinking this? Also, the relationship to innovation and the relationship to being inventive, because I think we know that users are not necessarily inventive. I think that has been sort of now understood quite well. And I think so, especially in the health area, do you think we need to really rethink this, and what would be starting points to rethinking this methodology?
Yeah, I agree. Like, we were always taught, you know, the user comes first, ask the user knows best. And that's true to an extent, but I think you're right. I think in health and wellness, and especially in VR and AR, we've learned that sometimes you don't know what you want because you don't know what's possible. So one of the tools that we've used, and I'm sure you've all used this kind of technique before, is to kind of look at possible futures. So to actually present not the solution, but to say, look, here's what you could do if you use this immersive headset, or here's what you could do if you track your blood glucose with a continuous monitor. So we present possibilities and then use them as technology probes to try and see if we can decipher it that way. It's slightly safer than saying, here's our solution, would you use it? Because clearly that's not good practice. But it, you know, sometimes starting with an empty slate doesn't work because we can't always imagine what we might want. I mean, I sent a survey to 150 older adults, and older in this case was over 65, which is actually quite a young older adult. But about 50% of the surveys came back annotated saying, I can't answer this, I'm not old. Right? Now, we defined them as old because that was the WHO definition of old, but they wouldn't answer our questions. So we missed half our data set because we asked them, you know, would you like a reminder for your medication? If you did, would you want it through your watch or your TV? They wouldn't answer any of the questions because they said, I'm not old enough to need it. That was our error. And what I think we need to do sometimes is to give people possible scenarios and possible futures to say, can you imagine what this might be like? Would you want this in this context if it might help you from going into a hospital bed or a home? And that's harder for us to imagine as humans, but it's the only way I can think to try and do technology design with the user still at the center.
Great. We have another question from the audience, and